Vanakkam. We have learnt in the previous videos about how the shoulder can be affected in birth brachial plexus palsy. But can the elbow, forearm and hand also be affected? Yes, they can. Maybe not as much as the shoulder, but definitely can be affected to a level that may cause serious disability in the activities of daily living also. In what ways are they affected? And how do we assess the problem before we can prepare for treating them? This is what is going to be dealt with in this video. We have seen the shoulder problems that can occur in birth brachial plexus palsy affected children. In this video, we shall see the elbow and hand problems that are going to occur. And when we talk about the elbow and hand problems, we are going to talk about the secondary problems of the elbow, the secondary problems of the forearm, and secondary problems of the hand and wrist. Among these, the secondary problems of the elbow in birth brachial plexus palsy are the most common. In fact, they are the second most common secondary deformity encountered after the shoulder joint. A study showed that the median age of onset of the deformity of the elbow was 5.1 years, and it was associated with radial head dislocation in 6% of cases. What are the different problems that can occur in the elbow in children affected by birth brachial plexus palsy? There was a large series of follow-up studies done by Zancoli and Zancoli et al. In the year 2000, and it revealed that flexion contracture of the elbow was seen in 62%, weakness of extension in 46%, and weakness of flexion of the elbow in 18%. The study also revealed that there was no significant association found with the extent of brachial plexus involvement with elbow involvement, but others have noted increased prevalence and severity of elbow flexion deformity in NARACAS groups 2 and 3 as compared with group 1. The problems in the elbow could arise because of a muscle imbalance, the strong elbow flexors versus the weak extensors, the contracture of biceps due to partial reinnervation that occurs in birth brachial plexus palsy, or a combination of both of these. It could also occur due to adaptation to an abduction contracture at the shoulder, and it could also be due to an attempt to stabilize the shoulder by activating the long head of the biceps. In this example, you can make out the prominent biceps that is put into play when the child is asked to abduct the shoulder. So this co-contraction of the biceps is what has caused the elbow contracture in this child. It has been postulated that there is a sequence of the development of the problems of the elbow. Secondary to recovered strong biceps muscle amid weak or absent triceps, pronator teres and the pronator quadratus muscle, flexion deformity occurs at the elbow. This leads to further progressive loss of elbow extension, which may be associated with subluxation or dislocation of the radial head. The unopposed action of the recovered or reinnervated biceps leads to an elbow flexion deformity along with a supination deformity, and this gives a characteristic attitude to the affected limb manifesting with progressive difficulties with day-to-day activities, especially eating. Al-Khattan, in a study done in 2002, noticed that elbow deformity was often associated with the shoulder internal rotation contracture. So he believed that these children stand with the shoulder slightly abducted and hence the elbow falls into slight flexion. And why they stand with the shoulder abducted is to place the limb away from the body in a better functional position. This constant flexed posture of the elbow also contributes to the elbow flexion contracture. The degree of flexion of the elbow deformity could be the basis for the classification. It is said to be mild when the elbow flexion is less than 30 degrees, moderate when the deformity is between 30 degrees and 60 degrees, and severe when the elbow flexion deformity is more than 60 degrees. We need to remember here that the functional elbow range of motion is 30 degrees to 130 degrees. So, any contracture of more than 30 degrees may impair activities of daily living, including self-care. We have seen so far that a strong biceps against a weak triceps is the main cause of flexion contracture of the elbow. But it has also been noted that the flexion contracture was seen even if the biceps was weak. How does this happen? This paradox was investigated by Aitken, who noted the following changes developing. First, a proximal ulnar curvature. He felt that in these cases in whom the biceps was weak, the triceps was spastic, and when inappropriate splinting was applied, it led to the proximal ulnar curvature. By 7 weeks, he noted that there was clubbing of the metaphysis of the radius, and by 2 months, there was flattening of the radial metaphysis anteriorly. The upper radial shaft also started moving backwards. By 7 months, there was a notching of the previously flattened area on the metaphysis. By 2 years, the notch was spreading distally and the head of the radius subluxated and ultimately dislocated by 5 years of age. In this example, the fixed elbow contracture in the child, in spite of a good flexor function, showing anterior dislocation of the radial head and bowing of the ulna. Secondary problems are bound to occur in the forearm in children with birth brachial plexus palsy. That is because for a normal functioning forearm, we need the integrity of the proximal and distal radioulnar joints and a well coordinated functioning of muscles, the pronator teres, pronator quadratus, biceps brachii supinator and brachioradialis. And as we know, in birth brachial plexus palsy, this may not be occurring. There are mainly two types of deformity occurring in the forearm: supination deformity and pronation deformity. In the study by Zancoli and Zancoli et al. In 2000, the incidence of supination deformity was 69% and the incidence of pronation deformity was 29%. The supination deformity is commonly seen in extended Erb's palsy C567 innervation with forearm muscular imbalance, because in this condition biceps recovery occurs to a certain extent due to cross innervation while the triceps does not recover, or global palsy patients in whom some innervation of the biceps has occurred. In these patients, another feature would be wrist hyperextension and ulnar deviation due to the weak volar flexors and partial activity of the extensor carpi ulnaris. In a study done by Yam et al. In 2009, the supination deformity was absent in Narakas group 1, seen in 5.7% of group 2, 9.6% of group 3 and in 23.4% of group 4 Narakas classification. As we have already learnt, group 1 refers to Erb's palsy, which is involvement of C5 and 6. Group 2 is extended Erb's palsy and group 3 and 4 are total palsy of the plexus. The obvious cause of the supination deformity is the unopposed action of the supinators. That is, we have a strong biceps and a strong supinator muscle, both innervated by C5, C6 roots, which are acting against either paralyzed or very weak pronators, which are the pronator teres and pronator quadratus. Initially, passive correction of the supination deformity is possible, but as the child grows, the deformity becomes fixed because of the contracture of the interosseous membrane. So it becomes a supination contracture with a fixed deformity, and continued growth of the forearm with the contracted interosseous membrane leads to incurving of the forearm bones, bowing of the radius and ulna, and volar subluxation or dislocation of the distal end of the ulna or head of the radius. Supination alone is not enough for function. a pronation of minus 10 degrees to plus 40 degrees is required to carry out common self-care tasks. When there is extreme supination, especially when associated with wrist hyperextension, there is a greater functional loss in the hand. Some children with a supination deformity attempt compensation with flexion and internal rotation of the shoulder. This maneuver may be difficult for a child with a weak or unstable shoulder. So the supination deformity that occurs in children with birth brachial plexus palsy causes a functional as well as a cosmetic disability. The functional problem is because the child is unable to perform many activities of daily living, eating, writing and bimanual activities that require simultaneous elbow flexion and pronation. The cosmetic problem is due to the fact that the forearm is always kept supinated. It has been termed the beggar's posture, and when it involves the right hand, it is known as the unshakable hand. Such terms are not to be used nowadays, but it shows the extent of the deformity and the impact that it has. The typical supination contracture of the forearm with elbow flexion deformity. This hand is also showing the hyperextension at the wrist joint. Though of a lesser incidence than the supination deformity, the pronation deformity is also debilitating. It occurs due to the unopposed action of the pronators in the presence of paralytic supinators, and this occurs especially in C5-6 lesion Naraka's type 1 or the typical Erb's palsy. It can also occur in total plexus injury due to muscle imbalance during the recovery phase. So what starts the chain of events is the weakness of supination of the forearm. Where the biceps recovery is partial, the child uses flexor pronator synergy to assist in elbow flexion. The forearm is always kept in pronated position, and when this condition is not treated, it leads to a pronation contracture. This pronation contracture occurs due to the interosseous membrane contracture, ultimately leading to dorsal dislocation of the distal ulna and posterior dislocation of the radial head. The pronation contracture also causes a functional and cosmetic disability. If partial supination is possible, self-care, keyboard and tabletop activities which require the hand in pronation can be done satisfactorily, but if there is no supination at all, there is also an inability to carry out basic hand functions needing supination, like carrying objects, buttoning clothes, perineal care, eating with the right hand and accepting offerings in temples. The cosmetic disability is also obvious when a child with a pronation deformity of the forearm is seen. Pronation deformity of the left forearm in a child who has sustained a total plexus injury. Apart from the shoulder, the elbow and the forearm, the hand and wrist can also be affected in birth brachial plexus palsy children. The clinical presentation in the hand and wrist varies greatly from child to child and depends on the degree of spontaneous recovery. The study by Zancoli and Zancoli et al. Revealed an incidence of 27% for the ulnar deviation of the wrist and varying types of finger paralysis as a sequelae to birth brachial plexus palsy pathology. Chuang's series of 54 children with late newborn brachial plexus palsy was conducted in 2002 to study the various problems that could occur in the hand and wrist. Extension deficit at the metacarpophalangeal joints of the fingers was 60% incidence, thumb instability 37%, ulnar deviation of the wrist 19%, extension deficit at the wrist in 15%, digital flexion deficit 15%, and interphalangeal joint extension deficit in 13%. All these problems in the hand and wrist could occur due to a relative imbalance in the power of different groups of muscles acting over the wrist and hand joints, or they could be a result of significant co-contraction between the flexors and extensors acting on the joints. Ulnar deviation of the wrist is a very common problem that is seen. It is a result of the muscle imbalance due to the paralysis of the extensor carpi radialis brevis and extensor carpi radialis longus, along with the paralysis of the flexor carpi radialis on one side, against the unopposed activity of the extensor carpi ulnaris and the flexor carpi ulnaris. This deformity is a flexible deformity frequently associated with supination contractures of the forearm. The thumb instability that occurs in these children is also characteristic. It is due to the lack of abductor pollicis brevis, abductor pollicis longus, extensor pollicis brevis and extensor pollicis longus. Absent finger flexion is observed in total or lower plexus palsy. We have seen the problems that occur in the elbow, the forearm and the wrist and hand. But how do we assess them? It is mainly physical examination which is used to determine the need for surgical intervention. But the problem is testing against resistance in very young children. So, several classification and scoring systems for assessing function and predicting outcomes have been proposed. These classification and scoring systems can be broadly divided into three categories: muscle strength grading systems, joint range of motion grading systems and hand function grading systems. The mainstay of muscle strength grading systems is the Medical Research Council, the MRC grading system. The MRC grading system, though complete, cannot be used in children less than 3 years of age, as testing against resistance is not possible, and it does not assess the range of motion or the overall hand function. So, various modifications of the MRC grading were proposed, like the Gilbert modification, the Al-Katan modification or the Bharadwaj modification. Alain Gilbert introduced a modification of the MRC grading system for use in younger children that could not assess grade 4 and 5. Al-Katan has modified the MRC grading to include a gross assessment of the range of motion in older children. Bharadwaj et al. Gave a modification of the MRC scheme with 3 subgroups to grades 2, 3 and 4 respectively. It fell into subgroup A if the range of motion was less than or equal to 50% of normal, subgroup B if the ROM was more than 50% of normal, and subgroup C if there was full range of movement. To assess the joint range of motion, the Toronto test score came in very useful. There was a grading of 0 to 2 for all the movements, 0 signifying no movement and 2 signifying normal movement. With all this, a total score was computed. These tests do not require testing against resistance. The Hospital for Sick Children Active Movement Scale was proposed in the year 1995. This active movement scale is more comprehensive than the Toronto test score. It has been described in a previous video which can be accessed by clicking on the link above. Assessing the hand function can be done either by using the Dubosset scale, in which type 1 is normal movements of the hand, type 2 is where the hand is quite functional but slow, type 3 where the hand is very handicapped but sensate and pinch is possible, and type 4 the unusable hand with sensory problems. This system of classification does not take into account the intrinsic muscle function. The hand function can also be assessed in the birth brachial plexus palsy patient by the Raimondi scoring system. This system takes into consideration the supination at the forearm, the flexion of the fingers, extension of the fingers and movements of the thumb, especially opposition. So far, we have seen quite a lot of varied problems in birth brachial plexus palsy involving the elbow, the forearm, the wrist and hand. But what about the management of such conditions? This will be dealt in our next video on birth brachial plexus palsy. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about decision making in birth brachial plexus palsy and the surgical strategies that can be followed. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, trauma surgery, plastic surgery and ethics. Vanakkam.